Okay, everybody, I know that it's 9:30. We still have some people joining, so I'm going to give everybody a minute or two just to get settled in. I see lots of people chatting their information, which is fabulous. We want your name, your email address, and your agency or school or university. Please be sure to rename yourself so that we know who you are. All right, there might be a few people that are going to be joining us, but I think we'll go ahead and get started. I've been saying it over and over again, but we had a few more people join us, and it's really important. So what I'd like you to do is to please rename your screen with your first and your last name and your organization. You can do that by clicking on participant. You'll see that right on the screen now, and then click on your profile and rename your profile. I was trying to look to see within our participants, do we have anybody joining by phone? It does not appear as though we do. So I think we are good there. And I'll just then ask the hub to just chat anybody who has not renamed. We do still have a few people who have not renamed their profiles. So please be sure to do that and to chat Jessie with your information. We do have closed captioning. We have a captioner on here. I'd like to ask our captioner to also identify yourself in the participant list as captioner. That helps us when we go back to do the attendance later. And if the captioner could then share the link in the chat for anybody who needs closed captioning. If you need closed captioning, you can also message Jessie Thomas and she can help to set you up with that. Okay, so the other thing also related to continuing education credit, it's really important for all of you to do our pre and post session surveys, both for continuing education credit and just so we know how we're doing and what we need to do better and how we can most meet your needs. If you have, if you're getting OKRA credit, the credit is not automatic. Give us about 2 weeks to post that credit. For the Department of Developmental Disabilities, what we've done in the past is issue a certificate at the end of our 8 sessions. If you need that before that, just go ahead and email Jessie Thomas and she can get you a certificate for the individual sessions. Okay, also want to just remind, I know I spent a lot of time last week talking about this, but just to remind everybody that this is the ECHO model. So this is a little bit different than a webinar. We're going to be building a learning collaborative over these 8 weeks. And so really the goal is to teach all, learn all. I think everyone did a great job last time, keeping cameras on and talking. Just want to encourage you to do that. ECHO, the whole goal of it is to have an interactive community where we've got our presenters, our stakeholders, and our community members all working together and supporting each other at every session. All right, so what we're going to do too, Dr. Weber, if you could just go ahead and take us. We will do some introductions of our members and of our hub, and then I'll talk to you guys about our plan for today. Oh, it's so great to see so many wonderful faces on here. So we have a number of fabulous hub team members. You'll see them. Some of them have a background. Unfortunately, some of them, because their cameras are a little finicky, aren't able to have our ECHO Project Scope background. But the way you can always spot a hub member is they have an asterisk at the beginning of their name. So if you see them, you know that they're a hub member. We have myself, I am a clinical psychologist and the director of training at the OSU Nysonger Center. My partner in crime is Dr. Stephanie Weber, who is the training director at Cincinnati Children's. Jessie Thomas is our program assistant, and she helps with all things related to technology and Zoom. So if you have any issues, go ahead and contact her. We also have on our team a number of other fabulous folks. We have Dr. Riley Roberts, who is our trauma specialist and a clinical psychologist, Troy Hunter, who is a developmental specialist and also works within the early childhood mental health field. We have nurse navigators that work with new moms and expecting moms. We have Kristen Kerwin and Stacy Lee and Sue Meeks. We have Kathy Wedig, who is our speaker today. I'm going to spend a bunch of time talking about Kathy in a second. Rock star in all things in neonatal. Pam Williams-Aria, who is a developmental behavioral pediatrician. John Kinsel, who is an early childhood mental health specialist. Aaliyah Keeley, who is another developmental specialist. Amber Clark, who is a social worker. So without further ado, I would like to, in our agenda for today is we'll be doing the didactic with Dr. Wedig. We'll pause. You guys will all have time to ask questions. You can, because of the group size, it's going to be easier to chat your questions. And then we might ask you to unmute if you feel comfortable and follow up on that. Then we are very lucky. We have a case to talk about today. So 2 of our spoke members are going to be presenting a case. What they'll do is present the case. Then we all can ask any clarifying questions. Then at that point, we'll go into a breakout room where we'll be able to, within our small groups, help to generate recommendations for the group, and we'll come back and report those. So if you have any questions at any point, feel free to message one of our hub members. Otherwise, I'd like to introduce Dr. Wedig, and we can get started. So Dr. Wedig is the co-director of the Neonatal Abstinence Syndrome Clinic at Cincinnati Children's Medical Center. She's a clinical neonatologist with 37 years of experience in NICU care, is on the advisory committee for the PEOPLE grant, which is related to preparing early intervention providers for the opioid epidemic, the chairman of the Collaborative for Children of Addictive Parents, and just all around has an amazing amount of information that she's going to share with us. So with that, I'm going to turn it over to Dr. Wedig, who will share her screen and her slides.
Good morning. So today we're going to talk about in utero opioid exposure. We will start with the baby who experiences withdrawal during after this in utero exposure, but unfortunately for that child, the issues do not stop in the neonatal period. So we'll see how life has changed for these children. I have nothing to disclose at this time other than my interest in this is to show that there are no bad children, just bad things that can happen to children. So anybody who's been in a neonatal nursery may have heard a baby who just seemed in so much distress that everyone wanted to run to that baby's bedside. This, unfortunately, is the scene we have many times with a baby who has been exposed in utero to opioids and is now withdrawing. These children should never be considered addicted babies. They are not addicted, they are withdrawing. And so you may hear people talk about them having NAS, or neonatal abstinence syndrome, or NOWS, neonatal opioid withdrawal syndrome, to be more specific as to what they were exposed to in utero. The third acronym I have here, TND, toxic neurodevelopment, is actually one that I am using to explain how these children are at risk for further developmental issues. First, I'd like to look at what our burden of disease is in Ohio. This takes into account the number of children many of us may be seeing now, because this is from the past 2 to 4 years. And some things I want to speak to first, and that is that you will see that we have a high number of children who have been exposed. You may notice that in the Cincinnati area, the numbers look much higher than for the state of Ohio. But this is really the difference in the way children are identified. In our Cincinnati area, every woman who comes to deliver has a urine tox screen done at the time of delivery. So these numbers come from the number of positive screens. Throughout the state, the risk for a child to be having been exposed may be done differently. It may be a paper screen to the mother in which they look at her risk for opioid use, and may not be an actual drug screen. So even if we take it that we are just looking at the risk, you can see if 2.2% in 2016 of the babies were exposed, and there are 140,000 babies born in Ohio, that's 3,000 children throughout the state who were exposed to opioids. And then if we look at any exposure, because we have not been able to identify outcome just based on opioid exposure, we are increasing that to almost 5,000 babies, and that's only if you do a paper screen. If you do a drug screen, as we've done in the Cincinnati area, you're talking closer to 7,000 children a year being exposed to some drugs in utero. So what is neonatal abstinence syndrome? Neonatal abstinence syndrome is a constellation of symptoms that include central nervous system irritability. So babies who have very high-pitched cries, very prolonged cries, jitteriness, tremors. Very rarely, but it can happen that they have seizures. Gastrointestinal dysfunction, they have diarrhea, they have poor feeding, and probably have an upset in the gut bacteria, a dysbiosis. And they have autonomic disorders, which mean that they sweat, they have temperature instability, they have sneezing. So these are all symptoms that have been identified by caregivers in infants that are known to have been exposed in utero to opioids. These symptoms have formed the basis of what's called Finnegan scoring. And so if you hear that a baby had a certain Finnegan score, this is based on looking at 21 different symptoms of withdrawal and calculating a score. If a child at any time in scoring has greater than an 8, 3 times in a row, or greater than a 12, 2 times in a row, that child is considered to have significant withdrawal and is a candidate for treatment. We most recently, though, have looked at a score called Eat, Sleep, Console, and this is actually based on neonatal functioning instead of symptoms. This is a score that says, can this baby do what a baby should do, regardless of the fact that they have some of these other symptoms going on? So in those nurseries where Eat, Sleep, and Console is used, if a baby can eat at least an ounce every 3 hours, can sleep at least an hour out of 3 hours, and can be consoled from crying within 10 minutes, that child is considered to have mild withdrawal. If any of those symptoms become more significant, if the baby cannot eat, cannot sleep, cannot be consoled, then that baby is considered a candidate for treatment of neonatal abstinence syndrome. That treatment that I'm speaking of for when the baby goes beyond the scoring is pharmacologic care. And that is with either methadone or buprenorphine, otherwise known as Subutex, and phenobarbital and clonidine could also be added. Infants may be discharged on either phenobarbital or clonidine, but are not discharged on methadone or buprenorphine. I should note also that this is the method of care in our area. There are some areas where morphine is used in place of methadone or buprenorphine. But what we actually hope is that the non-pharmacologic care, swaddling, holding, quiet, dark room, and high-calorie formula will help a child get through the initial week or so of withdrawal that we see from the different opioids that mothers can take. Now, why do we see this? What is actually going on with the child, and why am I concerned that we're speaking of toxic neurodevelopment and not just withdrawal. We know from looking at a brain neurotransmitters that when a person goes through withdrawal, there are changes in at least these 4 transmitters. Dopamine, which is our feel-good neurotransmitter, decreases. This leads to a hyperirritability, anxiety. Serotonin also decreases, and this leads to the sleep deprivation or sleep fragmentation. Noradrenaline or epinephrine increases, and this leads to the tremors, the tachycardia, the high blood pressure, or the high temperatures. And acetylcholine, this increases, which leading to the diarrhea, vomiting, yawning, sneezing, sweating. All of these are symptoms that are measured in the Finnegan scoring. All of these can be seen in anyone withdrawing from opioids. So these are symptoms that the mothers will tell you happen to them also. Now, what is so concerning is that these neurotransmitters are found in our brains very early on. Epinephrine, dopamine, serotonin, and acetylcholine are present in the first trimester. So from the earliest development of the brain. And GABA and glutamate, which are other neurotransmitters we'll talk about, they are present in the second trimester. So with overactivation by the opioid drugs or withdrawal of these drugs, because if a mother is not in stable treatment with methadone or buprenorphine, she may be experiencing periodic withdrawals when she doesn't get her heroin fix today or her fentanyl. And their baby then is withdrawing. And so we need to be concerned about what changes can be occurring in the brain. So this is our brain reward center. This is the center of dopamine. All of us have this brain reward center. It is in our most primitive part of our brain. It is important because this is the center that tells us you need to eat because we are rewarded with eating, or you need to procreate. You need to have intercourse in order to keep your species going. But it's also a center that can be strongly affected by many things. As you might see, it is affected by nicotine and alcohol. It's affected by stimulants. Cocaine and amphetamine actually increase the amount of dopamine by decreasing its reuptake by the neurons. Even the cannabinoids, marijuana, can have effect on this center. So as we're talking about some of the responses we get from the babies, we may be not just talking about opioids causing these reactions. And then as we look at how we connect our primitive center of our brain to our thinking center, which is our prefrontal cortex, our executive center, that which helps us to organize our lives, you can see there's a very strong connection. The dopamine that is put out by the ventral tegmental area goes to the prefrontal cortex. When there is too much, the prefrontal cortex sends back glutamate to say, hey, there's too much here, let's slow this down with stimulating GABA. So all of these areas are very much connected. And if you look at the left side of the slide, you'll see how they affect us and how too much of one of these neurotransmitters may really lead to the issues that the children have. So the prefrontal cortex, as mentioned, is the executive function center. It's our cognitive control of behavior. When we have damage to the prefrontal cortex, we have a lot of difficulty with responding to our environment in a way that people find acceptable. The nucleus accumbens, which is one of the centers for dopamine, is our motivation to behavior. the amygdala. The amygdala is our emotional center to the brain. And in children who have been exposed in utero, this has actually been shown to have anatomic changes. But it's also our decision-making and memory center along with the hippocampus. The hypothalamus is our stress center. All of these fall together in that limbic system and connection to the prefrontal cortex. And as we see what goes on, we can see how this can lead to the toxic neurodevelopment we're talking about. Because in utero drug exposure is one of 3 things we need to be considering when we are working with children who have been exposed. This in utero drug exposure can be affected also by the environment the child's in. It can be affected by the genetics of the child. But it can also stand alone, such that you can have children who are adopted into or in foster care in very middle class, upper middle class, all advantages offered families who still can show symptoms of in utero drug exposure. And genetics may or may not be there for the different situations that the children are showing. Does a mom who may have a substance use disorder, does she also have ADHD? Does she also have obsessive compulsive disorder that's genetically based? So we must think about all of these 3 things. But I think that if we know that there's in utero drug exposure, we start working with the child just on that basis also. So here's some confounders to all of that, because children who are exposed in utero may also experience prematurity. They may have intrauterine growth retardation, where they're extremely small for their gestational age. Their mother might have also used cigarettes, alcohol, marijuana. She may have a low level of education, socioeconomic status. She may have mental health issues, and then the family genetics we spoke about. So these are all things we need to think about with our children. And so what does happen? Well, these abnormalities of the neurotransmitters we talked about have effect on all these different areas of the brain. It can have an effect on the visual center of the brain and on the retina. It can affect the working memory, inhibition, sense of body and space. The children who are bouncing off of walls or other children, they're not trying to do it for attention. They just don't know where their body is in space. May have difficulties with attention and with learning. May have what we may consider as abnormal fears or anxiety, abnormal attachment. Their muscle tone and movement may be either high tone or low tone. And abnormal gastrointestinal system. These are babies and children who really have, babies who may need formula changes because their gut really can't digest the usual formula. I find many of the children that I deal with either need the protein hydrolysis, or they even need Nutramigen, which is a meat-based formula instead of milk. This shows up with a lot of irritability, and so this is something that we need to take into consideration. The other thing that I will mention is that these children seem to have more eczema than other children. So I'm going to go through a few studies here that looked at groups of children. There is no study out there yet that can say, because you've been exposed to this, you will have this. These are children that we know have been exposed in utero. Opioid exposed, had neonatal abstinence syndrome, but that's not specific to where they exposed to methadone, heroin, fentanyl, oxycodone. So this is a group of children from Cincinnati Children's Hospital looked at age 3 to 4, and how many of them had been seen at the Children's Hospital for these medical issues. So what we found was torticollis, and I'll show you a picture of this, was 8 times more in the neonatal abstinence syndrome group than the opioid exposed, and 4 times more than overall children. Now, what I will mention is Cincinnati Children's is the only show in town in Cincinnati. It's the only place that children are admitted. So they're going to have a higher number of children from the community for this. The plagiocephaly, a flatness on either side of the head, was also more in neonatal abstinence syndrome. These two are thought to be related to the fact that many of the children in their treatment for neonatal abstinence syndrome are swaddled, then they have high tone, so their body gets into a certain position, and so particularly their head. Strabismus, or lazy eye, was even increased in those children who were opioid exposed. Otitis media was across the board the same. Hepatitis C exposure, very, very, very concerning. But 35% of the babies in neonatal abstinence syndrome were exposed to mothers who were hepatitis C positive. This is our new infectious disease problem here. This is torticollis and plagiocephaly. You notice that the baby has his head tilted to the left and has flatness of the back side of his, the right side of his head. Difficulties in children who have this, besides the fact that their, head does not look like it's on straight. But think about what their eyes are seeing. They're seeing they're on a slant, not on a horizontal. They are seeing one side of their body more in preference to the other side. And remember, babies don't know they have 2 sides, so they start to become handed. Either in this baby, he'd be right-handed, and children should not be handed until they're closer to 4 years of age. He may prefer to roll to just one side because he doesn't know that the other side is a possibility. These are children who have problems with lazy eye, and every child that's been exposed to opioids should have at least an eye screen looking for that the eye crossing. It is very important that children have their eyes working conjugately, or one eye will eventually become, quote, the lazy eye, the eye you cannot see out of, because your brain can only take one image. It needs to be a conjugate image. Both eyes need to work together. So this is a cohort from Boston that says some of the same things that the cohort from Cincinnati said. At this hospital, they had a higher number of children who had been exposed, 5.3% of their population, and 3.3% with NAS. They compared these children to 8,000 children who were not exposed, and the children who were exposed to heroin, oxycodone, or methadone. What they found was some perinatal issues. These babies were more likely to be intrauterine growth retarded or premature. They will move into what else they saw later, but this is to compare it to what was seen at Children's in Cincinnati when we looked at psychosocial developmental issues. Those children who had neonatal abstinence syndrome were more likely to be seen for a delay in development. And if they were opioid exposed, they also had difficulty with delay in development, behavior disorders, sensory disorders, and speech disorders were much more common in children who have been exposed to opioids than in children with no exposure. And the Boston cohort, they also saw in the first 5 years behavioral issues. They defined them more as ADHD, a conduct disorder or emotional disorder, or abnormal physiological development went along with those problems we talked about with eyes and plagiocephaly and torticollis. So they found that the children that were exposed or had neonatal abstinence syndrome also had these difficulties. This study is actually out of New Mexico and looked at behavioral outcomes at 5 to 8 months in children exposed to methadone or buprenorphine. This study is somewhat concerning in that these are moms who are in treatment programs throughout their pregnancy. The moms were excluded if they had used anything such as illegal opioids, cocaine, or amphetamine, but they could have some low alcohol intake, and they did smoke cigarettes and marijuana. Control moms did not use any illegal drugs, alcohol, cigarettes, or marijuana. And what they found at 5 to 8 months was there was no difference in cognitive functioning. And as an entire group, this we seem to see throughout the first 5 years of life, that there's not major difference in cognitive functioning, but there are differences in behaviors. So the exposed infants showed decreases in self-regulation and increases in sensory-seeking behaviors. There was higher parental stress if the baby showed signs of NAS very early on. So the shorter the time to treatment of NAS, the child was treated very early on and the parents had basically were not able to soothe the child, there was a higher degree of parental stress. And with longer hospital stays, there was greater parent-child interaction dysfunction. In a study out of Norway looking at mother-child interaction at age 4, these children were also exposed to methadone or buprenorphine. Mothers were in treatment. Yet 23% of the exposed mothers did drink alcohol and 100% smoked cigarettes. These are our confounders as we're looking at what can we project with children who have been exposed to opioids in utero. The control mothers did not drink alcohol or smoke cigarettes. But what they did find was that they could predict group influences, and by group, it means exposed versus non-exposed infants. This is not controlling for the mother-child interaction, but just in groups, and that exposed infants as a group had decreased behavioral inhibition, decreased sensory motor functioning, and short-term memory problems compared to when compared to the unexposed. If they just looked at issues based on mother-child interaction, this took into account maternal education, maternal drug use. They found that exposed infants had a decrease in narrative memory and vocabulary skills. So what this study was saying was that cognitive issues may be related to the mother you come from, but behavioral issues may be related to that what you're exposed to in utero. This study, also from Norway, was very interesting in an attempt to explain why children may have some of these behavioral issues. This study had the children use eye movements to predict another person's actions. So when these children could not use these eye movements, could not predict another person's action, they had negative developmental consequences. So this suggests that in a preschool situation, a child may not be able to predict what the teacher really wants them to do. And so they have difficulty imitating and learning from others, and therefore giving them social difficulties. This study was done by looking at a child, anticipate whether or not the ball was going to be moved based on, in the A situation, there was a person they could look at, and they could look at eye movements, and they could look at the person and anticipate, was that ball going to move? In the other situation, it was a machine that was moving the ball. They had no eyes to look at. And what was shown was that children who were not exposed, the control group, had some difficulty watching the ball if it was the machine that was doing it. But as soon as it was a person, they were very quick in following the ball. On the other hand, if the child had been exposed to methadone or buprenorphine in utero, they were actually even lower in predicting the machine, but they could not catch up as quick, even when a human was moving the ball. So maybe some of our children who are having difficulty in daycare or preschool just cannot interpret what they're being asked to do. This continues, unfortunately, even beyond the 0 to 5. This was from that Boston cohort we talked about earlier. And there, after 6 years of age, they found a greater increase in behavioral issues. Attention deficit hyperactivity disorder was more likely a diagnosis in children who have been exposed by 2.5 times. Conduct disorders, emotional disorders by almost 2 times. But as far as the medical issues we talked about earlier, the eye problems, the torticollis, the plagiocephaly, muscle problems, this was not diagnosed any more than their non-exposed cohorts after 6 years of age. As we move further along into grade school and look at mental health issues after in utero drug exposure, those children who were exposed to drugs without alcohol still had difficulty in emotional, conduct, hyperactivity, peer interactions, and had less prosocial behavior than the non-exposed group. When alcohol was added, those problems increased dramatically. Unfortunately, alcohol is not a substance that we can measure in drug screens, so it is very difficult to know how many of our opioid exposed patients are also being exposed to alcohol. This is a study out of Israel in which they looked at a developmental outcome of ADHD based on the home setting and drug exposure. So if a child was in a home setting where the father was heroin dependent, but the mother was not, there was a 24% incidence of ADHD. If the mother was heroin dependent and the child lived at home, 54% of those children had ADHD. If the child was not living with parents who were heroin dependent, and in fact were living in an adoption situation at a high socioeconomic status, they still had 21% of those children were showing ADHD. This was discussed as that this is not an environmental issue, this may be a drug exposure issue. In a study out of Australia, it showed that there was a progressively decreased ability to keep up with peers. This is, testing is done in Australia at grades 3, 5, and 7. And you can see that children who have been diagnosed with NAS were much further down in their test scores than their matched controls or the overall standard in New South Wales in Australia. So as we finish up here, I just want to kind of summarize those different age-based concerns and what resources may be available. So birth concerns. Does a baby have neonatal abstinence syndrome? Are they also premature? Do they have low birth weight? Have they had brain injury because of the mom may have actually delivered while she's in withdrawal? Do they have hepatitis C exposure? The resources that I can offer that we have are identification early by toxic screen of the urine or by maternal history, a good maternal history screen. And then having follow-up clinics for exposed and treated infants, recognizing that in utero drug exposure is a risk factor for development, regardless of whatever else the child is exposed to. In 0 to 6 months, we will still see muscle tone issues. They may have delayed motor development. They may have the torticollis, the plagiocephaly. We certainly can see sensory issues. Early on, in the first 3 months, some of these children just need to be held constantly. They don't sleep. They can be very difficult babies. They can have digestive issues. So again, resources, the NAS or exposed clinics, help me grow early intervention. An early intervention program for these children and parents is very important. Occupational therapy, physical therapy. 6 to 12 months, and we continue to see delayed motor development, feeding issues. When the child has moved from formula and is adding spoon feeding, you may see that they have very, very much issues with texture or of the food. This is the time that sleep problems are usually brought to the forefront because most people expect their babies to be sleeping pretty much through the night at 6 to 12 months. Eye problems are first noted at this time because it's after 3 to 4 months that a child should be able to coordinate eye movements. A child whose eyes kind of cross before that time, it's not necessarily a problem with the eyes themselves. And then you also can start to see ear and hearing problems. The children are more likely to have otitis media, may even need PE tubes. So again, you see the resources that are there. And in this one, I add parent-child therapy to the resources. 12 to 24 months, the concerns increase with speech language delay. Now child start to have different behaviors because they should be able to be starting to make their own person here. And if people don't understand them, they may start trying to get attention in other ways or sensory input in other ways, with throwing everything instead of playing with toys, throwing toys, biting, head banging. Sleep issues may also continue. And so resources are to consider sensory therapies through OT, consider speech therapy, consider sleep training. 24 to 36 months, now you may see these kids who are the terrible twos on steroids. Parents may have been able to handle the idea up to this point because they say, oh, he's 2, this is what a 2-year-old does. But now things are out of control because other people besides the parents are seeing the behavior. The child cannot play with toys. They're always moving. They go from one thing to the other. Poor attention, poor sleep, poor language. And again, moving through the resources, sensory therapy, speech therapy, developmental psychology, working with the child and the parent. 3 to 5 years old, you may see children who are now diagnosed with oppositional defiant disorder. They still have their speech delay, their poor attention, their poor fine motor, their gross motor delays. And we need to remember that they should be in a preschool program that addresses these issues. We should not wait until it's kindergarten time and have the child have difficulties. They can have an individual education plan. While we're thinking about the children, we should be thinking about the parents. We would love that every child who was exposed could go to a stable family that was their biological family. And we can increase this if we consider the parents along the way. So we should always be positive to the parents, support for parental sobriety, decrease the stigma of in utero opioid exposure. We want the parents to be able to say their child was exposed so that their child can get services they need. And they are not always coming to a new diagnostician who's trying to figure out why they are acting the way they're acting. The parents should be able to have confidence in their child's physician and especially medical services. They should have confidence in children's protective services. They should not always have to feel that somebody will be taking away my child. Child care needs to be educated to the needs of exposed children. School systems need to be able to identify and meet the needs, and drug prevention programs should work with the entire family. And when we get all of this together, we may be able to have this integrated care model. This has a lot of words on it, but what it really says is if we look at how the environment, the caregiver, and the child interact, and we put programs in place to make this the best it can be, that we can really help these children. So thank you for what you do. And these are the references and the acknowledgements. And right now, I'll stop sharing my screen and move on to somebody else.
Thank you so much, Dr. Wedig, for such an informative and nice, clear explanations of the neurological impacts, as well as understanding what those impacts are on the infants all the way up to those children. I know I found it helpful. I was jotting down things that I will want to share with providers going forward. I would like to open it up for questions, so we can go ahead and start putting some of those questions in the chat. I'm noticing that some of our questions are from our hub member parent, who is a foster and adoptive parent of a child who had neonatal abstinence syndrome. I neglected to introduce her. I missed her when I was introducing, and that's Michelle Hendricks. So Michelle is asking, Dr. Wedig, what's the best way to find primary care providers who are especially knowledgeable about NAS? And how does she best advocate for a child to get the best care, knowing the issues are related to NAS?
Yes, and that is our greatest difficulty. It is what our group, which is our Collaborative for Children of Addicted Parents, that has been our goal throughout our existence, which is almost 10 years now, to identify those groups that can really be, that advocate for children who have been exposed. I wish I could say we have the website up and going that tells those things. I think that every major hospital, major children's hospital in Ohio has participated in the different collaboratives for children who have been exposed. And I would start with one of the major children's hospitals to look for follow-up. We in Cincinnati, Dr. Weber and I have worked closely with groups, and we are always willing to try to answer that question directly for a person. What do we know? We are trying to get it down into a website.
Great. Oh, and I see Dr. Wedig too. The Dr. Weber also said she'd suggest asking a pediatrician or primary care practice professional if they have experience working with children with developmental disabilities, as many of the concerns may overlap. Michelle has a few other questions too. She's wondering if you could speak to the length of withdrawal you've seen in infants.
Yes. Actually, if you look at the drugs themselves and speak to adults, who have withdrawn from the drugs. The true length of withdrawal, if the child was not treated, would be less than a week. The real issues with this are how we measure what is difficult for the child, when are they withdrawing, and when are they seeing some other difficulties because of exposure during development. And I think as we use more of the eat, sleep, and console, we will talk more about the functioning of the child and less of withdrawal. So if you were to allow a child to withdraw, it would be pretty much over in less than a week. But nobody, like that first baby I showed you, nobody can sit and say, I can't do anything for this baby, I gotta let him cry. And so when you give methadone or morphine or buprenorphine, you are helping the baby to settle. So I know I didn't answer that directly, but it has to do with our difficulty in knowing what to do and what are we trying to do for the children? Are we trying, early on people were always concerned we were trying to prevent seizures. In the now almost 13 years I've been following these children big time, I have seen 2 children that had seizures and they probably were not related to the withdrawal. And you will find that there are many people who write, if a child who's been exposed has seizures, you should look for another cause for their seizures. You should not just think you need to treat for withdrawal. So we have this fear that we're going to do something neurologically to the child if we don't treat, but we don't have the best ways of determining which children need to be treated. We are working with the best that we have, but we continue to look more and more for ways to determine.
There's another question. What are the best online information resources to share with caregivers of NAS babies and kids? That's a difficult question. Many of the places that have NAS clinics will have their own brochures. As far as it, with each caregiver, there's different things that people need. We do have, I know that Help Me Grow and Early Intervention do have different ways to soothe babies and to work with babies. I would encourage people who are taking care of the children to work with early intervention to address each individual child's needs. Yeah, I think that's great. The other thing that we'll be doing as we go through this is we have pulled together some various resources and that could be something we could go through our guidebook resources to maybe pull some of those out and put in a handout for the parents and other providers on here as well. Another question, are you aware of studies that demonstrate the effectiveness of interventions early on that mitigate the issues that you've delineated?
I am not aware of studies that indicate that you can mitigate. I think that the difficulty is still that there are no clear studies that speak to what the child's exposed to. I know if you look in the fetal alcohol literature, there are certain studies when they know the child was just exposed to alcohol, but I think we are talking about a wider range of exposure.
Okay. Anybody else have any questions that they'd like to put in the chat?
Andrea, I'm on a little private chat here, and a really good point was brought up by Emily Moore about maybe the rates of children identified in adoption situations are more due to those parents being able to be connected to services. So it's more likely that they're identified with ADHD because the parents have the means to be able to seek the treatment, similar to the way in which that we know women are more likely to be identified with depression than men, because women are more likely to seek the treatment and have the documented disorder. So I think that's a really good point, that there's probably a lot more ADHD or other disability related issues in kids that are not with their or are with their biological families, but maybe they don't seek the support and get the documented identification.
Yeah, that's a really good point. I think, and that speaks to some of those things that Dr. Wedig talked about reducing the stigma related to the exposure and really trying to create that whole model of care, right? So that parents feel supported as they go through things. Now it looks like Tanya says, Tanya Rose says, I work with preschool children. I miss the infant toddler stage. What other signs and symptoms should I look for in children ages 3 to 5? And what are some of the things I can do to help children and families?
I think that maybe Dr. Weber can actually speak to that. Also, the children 3 to 5 are those that are trying to express who they are and have limited resources to do that. So I usually refer those children over to Dr. Weber. So I'll let her speak to some of the things that we've discussed.
Yeah, I will briefly mention that I oftentimes recommend for those children many of the same interventions and strategies that we would use for children with other disabilities. So things like a visual support to help them understand their day, things around limiting the stimulation in a classroom, trying to make sure that they have as much individualized attention as possible. But what's really nice is that we have set up the rest of this curriculum to further identify those strategies as we go. So please come back and join us in the next sessions that we'll talk about at the end of today, because we will have Dr. Raleigh Roberts talk about trauma-informed strategies for these kids. We will have our speech language pathologist, Dr. Razorbecker, talk about speech interventions. And then we have some amazing occupational therapists that will talk about sensory interventions and later on in the series. So please come back for more specifics.
Yeah, great. Thank you, Dr. Weber. And I think that the other piece that I have taken when I've worked with kids and seen them in that school age piece is also just thinking about what Dr. Wedig said about the dysregulation. When I see children that just seem to be not know their time and space, whether I know whether they have exposures or not, yet again, just putting in preventative strategies, but also realizing that emotion regulation stuff might be key to what's going on. I know it's time for us to do the case. I want to be respectful of the folks who have also asked questions. So I will just ask those quickly and then we'll move on to the case. So Jane Seitz is wondering about the role of Safe Babies Court to support the many treatment needs of child and parents. And I'm not familiar with Safe Baby Court. I don't know if you are, Dr. Wedig.
Yes, Jane and I have worked together on this. Safe Baby Court is the concept that a child who is in the custody of their parents, but their parents cannot, quote, get life together, should have their day in court sooner than what now happens. There are children within the state of Ohio who go well beyond 2 years in foster care while the situation is being reviewed while they go back to mother. So Safe Baby Court is putting into place strategies and help for the families to bring the children back to the family within a less than 2 year period of time. And if that doesn't happen, then the child should have their day in court and be released from the custody of their parents who have been given multiple chances and multiple strategies to help them parent.
Great, thank you for clarifying.
So I was just gonna add in, that the guardian ad litems are key with the Safe Baby Courts. And so they have an instrumental role in making sure, so understanding neonatal abstinence syndrome, but then all of the sequelae that we've been talking about this morning so that we can better advocate for those kiddos.
Great, thank you. All right, I want to make sure there's so much to talk about and so many great questions. We'll be lucky enough to have Dr. Wedig joining us for other sessions as a hub member, as well as Dr. Raleigh Roberts and other I would like us to have time to be able to do our case for today. So at this point, I would like to switch us to our case presentation. So after the course is over, you'll get a post-course email that we want you to fill out our post-evaluation summary that also gets you access to the recording, as well as all of the documents related to recommendations and all of those pieces. And I believe that Jesse will put the link to register for next week's, or in 2 weeks, our session in the chat in just a little bit. That will be related to addiction and treatment. And we have Drs. Walensky and Horseman, a psychologist and a psychiatrist, who will be talking about that. I want to thank all of you so much. This was such a great session. We ran out of time. We had 90 minutes and we could have talked longer. So I'm very excited to keep working with you guys through these weeks. If anybody has a case that you would like to present, please email Jesse. You can see it's not super high pressure. You get a whole team helping to help you problem solve. And that's what we're here for, because we all learn from each other. All right, thank you so much. And feel free if you have any questions, the team will stick on here for a little bit if you have any questions or anything of that. And otherwise, we'll see you in 2 weeks.